Okay, so now we are moving on to tests and measures lecture number 3. We're going to start with palpation, okay? It's going to be important when your patient comes to you with some sort of neck pain. There probably are likely to be some muscles that are either tight or tender to palpation. Perhaps your patient prior to coming to see you has been telling you that certain muscles feel really stiff and painful. So we're going to want to evaluate the soft tissues of the upper quadrant. I think I told you in the lecture that I'm going to come and do hopefully 8 hours of a soft tissue lecture. So I'm just going to pick out some important things as they are related to the cervical spine, and I'm not going to do a full soft tissue assessment of all of the tissue layers because that's not really what this is about at this point. Okay, so we're going to start anteriorly, the cervical spine. So go ahead and lay down on your back, please. Okay, and we're going to start with muscles, okay? And some of muscles that are typically need addressing with respect to the cervical spine, okay? Obviously, I'm always going to just start by looking at kind of the resting tone of the muscles in the anterior part of his neck. I may even just palpate for temperature changes. Again, I'm not doing a full soft tissue assessment at this point in time, at least not for this video. But, you know, if I'm noticing redness somewhere, or I might just do a quick little temperature assessment, okay? I'm observing and I'm looking for swelling, perhaps, if there's swelling anywhere. But really you tend to see increased tone in muscle. So a lot of times if somebody's having anterior neck pain, let's say they have whiplash or something of that nature, their SCMs are going to be if there's increased tone in these SCM muscles, you are likely to just be able to see the borders of those muscles better than if they were more in a relaxed state. I'm also looking at his clavicles, and I just want to see how those muscles sort of interact with those bones, and whether or not there is, if there's increased tone in the scalene, sometimes there's not as much of a, what's the right word, definition of the clavicle. If these muscles here have so much increased tone, it's like almost like their neck runs right into their shoulders. Okay, so muscles, anterior cervical spine. What do we want to start with? We're going to start, we talked about the SCMs. So remember, there's 2 heads to the SCM. We have the clavicular head and we have the sternal head. So a lot of times I'll just start by evaluating those attachments to the sternum and to the clavicle. And I'm always saying, is that tender? Let me know if anything that I touch is tender. And I'm going to do that bilaterally. And the tendons here where they attach to the sternum and the clavicle are very easy to palpate. So it's a great place to start. Okay. And then I can palpate the muscle belly of the SCM, and I can almost pick it up between my index finger. Is that tender?
No, just tickles.
A tickle. He's really ticklish.
I'm not.
Just when I do this.
Yeah.
Are you a little squeamish? Yeah. Does that hurt or is that ticklish?
Where you had your thumb.
Yeah. Not uncommon in people who have forward head posture to have sternocleidomastoids that are tender. Can you come up this way? Can you see what I'm doing?
Yeah.
Okay. So that is the SCM. Okay. The scalenes. So remember, the scalenes are in that posterior triangle. Can you see?
Yes, I can.
Of the cervical spine. Okay. So remember, the posterior border of the SCM was the anterior border of that posterior triangle. So we know that this triangle in here is where we would find the scalene. So I'm going to use my fingertips. I'm going to make sure you go in with gentle pressure, because in a patient with neck pain, especially a patient who has potentially nerve irritation and symptoms out into the upper extremity, if you remember what comes out in this area in the posterior triangle between the anterior and the middle scalene, I can hear you guys all saying, that would be the brachial plexus, the rami and the trunks. You are correct. Okay, so In a patient where there's nerve irritation, as I palpate in here, they might tell me, ooh, that's really sensitive. May even reproduce some of their radicular symptoms in their upper extremity. So you can palpate the scalenes. If I move posteriorly and somewhat superiorly, I can catch the splenius capitis and cervicis, and then the levator scapula muscle. But levator we're really going to palpate when after I turn him prone, okay? But you can palpate levator as it attaches up here between the first and fourth cervical vertebrae to the transverse processes. Okay, so that is anterior. If I want to palpate his longus colli and longus capitis, I am going to kind of scoop his come to the posterior border of SCM, and I'm going to kind of lift them up, and I'm going to try and sneak my finger pads around the anterior aspect of the vertebral bodies, because remember that's where longus capitis and longus colli are. So I'm like this, okay, and I'm palpating along the anterior aspect of his vertebrae and palpating those muscles. Okay, is that tender?
Not really.
Not really? Okay, and he doesn't have neck pain, so they very well may not be. Okay. What else do I want to palpate anteriorly? Oh, pec major and pec minor. Big ones, okay? Big muscles. I'm not saying that you have big pecs. Sorry, dude. Okay? Remember, pec major
I'm
here.
jacked.
You are jacked, aren't you? Yeah.
Might
So-
be the steroids.
Be quiet. Okay, so I can palpate through pec major, especially if he's, complaining of anterior superior chest issues. Now I've already talked about how far forward his humeral heads are and how I felt like especially on the right, his scapula was protracted and downwardly rotated. I expect, due to his postural issues, that his pec minor is probably tight. Now, we haven't assessed the length of the pec minor yet. We're going to do that in the next video. But what I'm going to do is I'm going to follow his clavicle out towards the AC joint, but in this concavity here. And then I'm going to drop into the squishy space. Ooh. And you watch their face, because you can tell a lot from somebody who's not speaking to you. Is that tender
Yes.
in here? Okay, so remember the pec minor attaches to the coracoid process and then comes and attaches to the anterior aspect of rib 3, 4, and 5. So I'm going to palpate with a few fingers in that muscle. That tender?
A little bit.
Yeah. No. No, we do not need the video on his face unless they want to see him making ugly faces at me.
I'm beautiful.
He's humble too, apparently.
The
Okay,
most
so
very humblest.
not uncommon to have pec minor tightness, but also tenderness. It's not uncommon to have trigger point, like right there.
Oh my God.
Yeah, see, he likes that. So I can just stay here
Yeah.
and hold some pressure. But we'll talk about treatment of soft tissue dysfunctions when we get to our soft tissue lab. But if you do happen to find trigger points along the way, stop moving, please. You can stop and hold some pressure. The idea, we call it ischemic pressure. If you hold pressure on the trigger point, you're denying it blood flow, so the muscles can't continue to contract, and so they let go. That's kind of the basis behind holding pressure on trigger points. Anyway, so that is his pec minor. Okay, so then I'm going to start with some of the muscles posterior because I actually think they're easiest for me to feel. So now I'm thinking posteriorly. So why don't you come here and down a little bit. So I am going to hold his head in my hands. Okay, I'm cradling his occiput, and I'm going to put my fingers here.
I'm pulling my hair.
I'm pulling his hair. His hair is very long and delicate. Sorry. So, you're catching his crazy hair from trying to grow it out from an undercut, in case you guys know what that actually is. So, it is in a very strange period of growth at the moment. And so at the moment, you can see he's kind of walking around with a mullet. But we love him anyway. and he refuses to get a haircut because he wants long hair. So we're in that awkward phase. Okay, so what I am doing is I have palpated the nuchal line of the posterior aspect of the occiput and moved into this kind of meaty muscular area just inferior to it. So I am in his likely, the first muscle that I would feel would be the upper trapezius. And then underneath that, probably catching some fibers of splenius muscle and then semispinalis. So I'm just palpating those muscles. Palpating for you right now and practicing. You keep that still. Thank you. Palpating for, I found something here. You feel that?
Yes.
Feeling for trigger points, but I'm just comparing bilaterally. I'm feeling for increased tone on one side versus the other. Symmetry is important, and also reproduction of symptoms. If I'm poking in here and he says, "Ooh, that's the headache I always have," that gives me a lot of information. Okay, that, hey, maybe that headache you always have is because of this big fat trigger point right here in your paraspinals, because I feel that. Okay, the other things we can palpate posteriorly, muscle wise, let's see, upper trapezius. Okay, so here you can see his upper trapezius, so I can slide my fingers under here and actually grip and grab his upper trapezius. Okay, and I would do that on both sides and ask him about tenderness, and for me, I'm assessing the tone of those muscles. And I can also go a little bit more posterior, so kind of roll this way a little bit so they can see this superior medial border of his scapula. And lay back this way, and if I let my finger sink in there, remember what attaches there? A tender too. Levator, okay? It's proximal attachment to the levator scapula muscle. Okay. Okay. What else do we have? Okay, so now I want to just talk about bony palpation. Okay, and once I turn him over, I'll go back to those scapular muscles. Obviously, he's laying on them right now. But some of the things that I want you guys to start becoming familiar with from a palpation standpoint is one that I've already talked about a lot, and that is, are you videoing me?
No, I got his head.
Can you see my hands?
Yes.
Okay, or this suboccipital ridge, and so palpating that bony landmark, because you notice I keep going back to that spot. That's going to be something that we hold on to a lot as we do joint mobilizations in a little while. The mastoid process, okay, so right behind his ear, this bony contour here. Sternocleidomastoid attaches there, as well as some other muscles posteriorly. So it may be an area that when we start doing soft tissue work around bony contours that you come back to be able to palpate that. The articular pillars, okay, the articular pillars, I showed you in a picture when we talked about the functional anatomy of the cervical spine. And so it's, if you remember the picture where it showed you the kind of the lineup vertically of all of those facet joints. Okay, so you need to be able to learn to palpate the articular pillar. So what you're going to do is you're going to take your hands around the neck and you're going to palpate the spinous processes with your fingers. Okay, so that's going to orient you to midline. I'm going to remember the first spinous process that you feel as you move inferiorly from the occiput is the spinous process of C2. Okay, so I have my fingers on, can you come up a little bit and see? There you go. On the spinous processes, and then I'm going to move about a thumb's width laterally. Okay, and I'm going to aim my finger pads from a posterior to an anterior direction, and I'm going to let my fingers sink through those soft tissues deep enough to the point where I feel like I reach a hard barrier. Okay, so I've sunk through the tissues, and now I feel like I'm up against something that's giving me more resistance, which should be bone. Okay, obviously those facet joints are made of bone. Okay, so hopefully I have made it, if I'm too medial, I'm on the lamina of those vertebrae. And if I'm in the right spot, I should be able to glide my finger slowly up and down and feel a series of peaks and valleys. Okay? If I had my spine model here to show you, I would actually show you, but I don't have it because it is at home at the moment. But the next videos I show you, I will have the spine, and I will come back and show you this. But I want you to just practice on somebody else, moving about a thumb's width laterally from the spinous processes, sinking into where you think the articular pillars are, and practice finding or noting that as you move your fingers up and down, you feel like there's a peak of bone, and then as you move up or down, you kind of dip into a valley. Okay, the peaks are the facet joints. The valleys are the spaces in between. Okay, and I can do that up and down the entire cervical spine. It takes practice to know that you're there. Okay, but I want you to practice this because it's those peaks that we're feeling. Those are the facet joints between the vertebrae. Okay, you're going to need to be able to palpate those in order to do accessory motion testing and joint mobilizations. Okay, so those are the articular pillars. Go back and look at that slide that I showed you in the PowerPoint in the functional anatomy lecture. Okay, and then I want you, if you can, to just practice palpating this on somebody. Okay, because that one is really super important. The other thing is the first rib, also something important. This will get revisited in thoracic spine, but I just want to show you now anyway. Go ahead and stand up, Ethan. What we're going to do here, I'm going to have my forearm angulated towards his left ASIS, so kind of towards his opposite hip. I'm going to palpate his upper trapezius, and I'm going to sort of move it or scooch it posteriorly down towards the table, and then I am going to, in the direction of my forearm towards that opposite hip, let my thumb sink through the tissues until I feel the hard kind of resistance. That should be the first rib. You feel that? Tends to be tender and right there. And most people, if you spring on it, you should feel it should be springy. In patients who have an elevated first rib or it's stiff, it's not as springy, okay? But I am aware under my thumb that there is a rib there. So you kind of put that upper trap on slack, and then this way I let my thumb sink in towards his opposite ASIS until I feel a bone. I feel the presence of bone underneath my thumb, and that is the first rib. Okay, so that's another thing that takes practice. Okay, because mobilizing the first rib is something that I do a lot. Okay, with my cervical patients and even my thoracic patients. Okay. Okay, the last thing I want to do, go ahead and let's have you turn over on your belly. Okay. Is I want to palpate the spinous processes. So I can sit here at the head of the table here and find the first, so here's the occipital ridge, and then I'm going to palpate down in the midline until I find C2. Okay. And then I'm going to palpate C3, and I'm just walking my way down the cervical spine. What I like to do is take a thumb on each side and kind of outline each side of the spinous process, okay? Just to get an idea if perhaps one of these spinous processes is way offset from the one above or below it, okay? So I'm just doing a quick assessment for alignment. Now, if I feel one that's like a teeny bit over to the side versus the one above it, does that mean that one of them is rotated? Maybe not. Maybe that spinous process just has a weird bony contour to it. Eventually, you'll learn as therapists, it's what's more important is how the segments are moving when you assess their mobility than what you think you feel when you're trying to palpate alignment. Okay, and then be able to palpate your scapular borders, okay? Practice palpating the medial border of the scapula. Practice palpating the spine of the scapula. And then from a muscle perspective, when I was palpating muscles before, and I said I would do this when I turned him prone, make sure you come through and you check your rhomboids. Remember, rhomboid minor attaches here at the base of the spine of the scapula. So I'm palpating his rhomboids. I'm comparing sides. I'm assessing for increased tone. I'm also looking for potential tenderness and trigger points. Okay, so now moving into pec minor. I can also catch levator at this superior medial angle up. Ugh, that one's crunchy. You feel that? Yeah. Okay, so that covers muscles and some really key bony landmarks for the upper quadrant. Okay. Good, Ethan. Stop the video. You did?